All right, chapter 11, pain. So pain is a universal subjective experience. It's a multifactorial phenomenon. It's not only physiological, but as described here, it's emotional, sensory experience shaped by biological, sociocultural, and psychological factors. Right, so it's a complex experience, but the patient's own experience is never the same as another person's, meaning it's a completely subjective experience. No two pains are alike. We can't ask the patient to prove that they're in pain, meaning although there are physiologic or there are behavioral indicators of pain, but the absence of any vital signs changes, the absence of a physical or behavioral evidence of pain does not mean it doesn't exist. It's kind of hard for nurses and all practitioners to accept, because in in our common, if you use common sense, it doesn't really, and we use our own biases, our own experience, and then impose it on the patient, which is actually unfair. We tend to correlate the absence and presence of pain with evidence, right? Let's say, who are moms here? Who are mommies? Uh, are you a mom, Sheila?
I'm a mom.
All right. So when your kids complain to you that they have pain, do you believe them every time?
She's only 3, so I do believe her. Yeah, I
Um,
do believe her.
but the older kids, who has older children here? Not children anymore.
I don't believe kids because some of them lie, especially if they have to go to school. So I don't believe them all the time.
Okay.
Okay. All right. So that's what I'm trying to say. It's as stated here, it's challenging both assessment and treatment of pain, because it's highly subjective. And if, let's say, we read um, the patient's history, let's say if it says there that they have a history of opioid abuse, or they are junkies, for instance, or let's say in report, the previous nurse who gave you report influenced your outlook toward the patient, meaning in report you were told that, oh, this patient has been on the call bell constantly, every hour, sometimes every 30 minutes, asking for pain medication. Man, it's driving me crazy. All right, so it can be both your pain experience or your perception of somebody's pain signs and symptoms can be influenced by other people, and then vice versa. A patient's pain experience can also be influenced by their parents, for instance, or their culture, their ethnicity, or by their own previous experience toward pain, and their own previous experience toward the caregivers that manage the pain, right? So it's a very complex experience. It's a very complex disease to treat, right? Regardless though of how we see pain, the person experiencing it is definitely suffering. So it doesn't only affect them physiologically, it affects their social relationships, their professional performance. Let's say, how many of you have had pain and then had to do something, meaning you went through pain, you worked through pain, you still showed up for work, you still took an exam besides being in pain? Who has done that?
Me.
All right.
Me.
Yes, so most of us had to
Me
do
too.
um, with pain, right? I mean, we had to deal with it at some point in our life. I remember walking with a really sharp pain from my left buttock down to my left foot, and I couldn't, I had to walk, I had to go to work. So so each of us had to deal with it at some point in our lives. It could be a tooth pain, for instance, which is one of the worst, right? For those of us have had bad tooth pains in the past. Um, and they always seem to happen at the worst time, in the middle of the night, wherein there's no doctor or dental offices open. They have the worst timing, right? So let's look at how we as nurses are asked to manage pain. Our definition of pain is stemming from McCaffrey. Um, she is a nurse, actually. She postulated, she developed the definition of pain, which is widely accepted by us nurses. Okay, not only nurses but also doctors. Of course, there are many belief systems that doctors don't. Not all practitioners accept McCaffrey's definition of pain, and therefore it will also affect how they treat pain. Okay, so let's begin with the gate control theory. Now, this is not testable. I'm just trying to explain the theory. So this is the gate control theory. They say that pain, since it's just like any other sensation, because we have pleasant and we have unpleasant sensations. So the theory says that all pleasurable sensations, like eating your favorite food, watching your uh, watching a nice show, watching a movie, going out with your significant other, eating ice cream, eating your favorite food, whatever that is, having sex, um, playing with your children. So all of these pleasant sensations run through large nerve fibers, meaning everything pleasurable, everything nice goes through a large nerve fibers. Whereas unpleasant sensations like hunger, pain, um, we watch something unpleasant, right? Noise, for instance, all these negative sensations, or what we say unpleasant sensations, go through smaller nerve fibers. Now, if you look at it this way, so say for instance, if um, I stroke Davian's elbow, for instance. So let's say me and Davian are seated next to each other, and then I constantly stroke her elbow, on the inner part of her elbow, constantly, very slowly. At first, will that bother you, Davian?
It would tickle, no?
Yeah, right. Definitely, right? But the more I do it, so let's say I do it every single day for the next 6 months.
It'll become painful.
Right. So you get no, you learn to ignore it, right? So let's say you can't stop me. Let's say I'm just a creep, a weirdo, and I never stop that. And then you can't, you have to be seated next to me because there's no other seat available. Let's say, all right. So you get used to it. So imagine that happening with pain. So if you have pain every single day, what will happen? Will you react to it the same way as the first day or the first few weeks?
No.
No. No, right? So you turn to, so we call that tolerance, right? So that's your threshold for that sensation, including pain. So our thresholds will change. Now, back to the theory, they postulated that if you have a pain stimulus, so all sensations travel up and down the spinal cord, right? So if you close the gate, for instance, closing the gate, we have different ways to close it. One is by giving pain medications, opioids, non-opioids, or it could be massage, it could be music therapy. So it could be um, pharmacologic or non-pharmacologic pain relief measures. Okay, so the theory is you close the gate. Once that gate is closed, then the pain sensation will be unable to travel up to the brain. So therefore, no perception of pain. Pain is non-existent. Right? So this is a widely accepted theory. So by ways of closing the gate, though, will matter or will differ from one caregiver to another, one provider to another, one patient to another. Right? So this is all a matter of closing the gate, meaning you stop the pain sensation from either getting through the brain, or in the case of opioids, you can also change the brain's interpretation of pain. So let's say you give opioids, so they will interfere with how you feel stuff. So for those of you who have ever taken opioids, I personally have no experience. I can't really describe, but for those who have taken opioids, they describe it as, like they turn almost numb. It like they can't feel their face, for instance. So that's how opioids close the gate. So it's not like they stop the pain, they stop the brain's perception or interpretation of the sensation, meaning instead of interpreting it as pain, they cannot, because you kind of numb the sensation. Right? So we have different ways of um, closing the gate, in quotations, closing the gate. You can do that through massage, for instance, meaning an example is there's a group of um, midwives. I saw them on the internet. The first time I heard about them was really in 19, I want to say 1993, while I was in nursing school. So they showed us a video. So they're more than we thought. I thought it was some weird cult, but it's not. It's actually a widely accepted practice. They're one of those midwives that deliver at home. They don't work in facilities. They they promote um, childbirth at home. So what they do is, so it's a familial affair, meaning the husband is there, the mom, so everybody's offering support. So while the woman is in labor, and they one group deliver inside a bathtub, or some of them just in bed. Either way, they have this because labor is a very painful experience. I mean, I can't describe it because I've never had it. My wife couldn't either because she had 4 C-sections, so she's never had to go into labor. So I don't really have any personal experience about labor other than in clinical. I mean, I've seen laboring women, but I don't really know. I can only see, oh, that looks painful. But anyway, the video we saw was the either the mom or the spouse, if the spouse is not available, during labor at the peak of a contraction, they stimulate the clitoris with their finger. So they as the contraction gets stronger, so the husband will perform a clitoral stimulation, and it actually follows the gate control theory, because now because it's the clitoral stimulation will of course stimulate pleasurable sensations, right? So therefore, and it's traveling through large nerve fibers, so they use that in order to stimulate larger nerve fibers, thereby closing the gate for the smaller nerve fibers, which is where the pain impulses travel. So that was one example of when they explained to us the gate control theory. I said, yeah, that made so much sense, because if you, it's all about which stimulus is bigger. Meaning, if you provide a stronger stimulus, it will drown out the smaller stimuli. Does that make sense? Or let's say another example is, let's say during sex, okay? um, there is usually no pain during the sexual activity, but then after the sexual activity you kind of feel sore, right? You're sore, you have pains in some places, but then how come there was no such pain during the activity? You get what I'm saying? And then afterwards, then you feel the pain. And then same thing also in sports. Let's say you enjoy the game, for instance. You have you're participating in it. It's very straining on your muscles, on your body, but then you don't feel it during the the activity. You only feel the pain afterwards. Okay, you can say that it could be the catecholamines, the epinephrine, um, causing the, but it's really the same thing. It's stimulating or providing larger stimuli in order to close the gate, um, conceptually, and then therefore eliminating pain. So this is our definition of pain. Pain is whatever the person experiencing the pain says it is. All right. So this is the pain definition used by nurses. Okay. We are, as in our profession, we follow this definition of pain.
Professor, I have a question.
Yes, boss.
So, what if you know that a patient is addicted to opioids, and he keep on asking for pain medication, asking for pain medication? What would you do?
Well, what did the definition say?
Says whatever the experience, but so, but I don't know because would you give them every minute?
Well, I'm not saying give them pain medication every minute. But do we have a choice not to believe the patient when
No.
this is our accepted definition? No. But neither are we saying that the patient will be 100% free, 100% pain free. Okay, we never do that. If you read all the statements of any facility, any hospital, any clinic regarding pain management, they do not guarantee 100% pain free, but all they guarantee is that your pain complaint will be acknowledged, it will be addressed, and you will receive pain management options. Right? That's all they're guaranteeing. None of them will say you will be 100% pain free, right? But the those pain management statements are also based on this definition, meaning we are obligated to believe the patient because again, the definition of pain is it's highly subjective. We cannot expect them to prove to us that they have in pain, meaning you can't say that a patient is complaining of pain, but then you check the vital signs and then there are no changes in the vital signs. Remember what I said about Davian earlier? When there is constant stimulation, do you still feel or do you still react the same way over time?
No.
No more. Okay, so it's very subjective. So you can't really here read this statement for me, Miss Janessa.
Although clinicians have largely accepted that pain is subjective, the subjectivity of the pain experience compels the need to prove that pain is present and challenge clinicians when observed pain behaviors are not consistent with other pain experiences.
So for those who are working at the bedside, how many times have you seen wherein a patient is asking for pain medication, right? And then when the nurse enters the room, they're either sleeping or on the phone laughing, right? Having a good time, conversing on the phone. And then when you ask, are you in pain? They say, yeah, I'm in pain. So do you have to have, so that's an example of the pain behaviors are not consistent. Meaning, why would you be in pain when you're on the phone or when you're sleeping? And then you tend to say, if I'm in pain, I wouldn't be sleeping. I would be bawling. I would be in a fetal position. But can we do that? Can we say that to our patients?
No.
No, because again, each of our pain thresholds, how we react to pain, are different. Okay, it's affected or influenced by several factors. Let's say in my culture, for instance, it's taboo for me to be bawling and crying. So I had my first experience when I was, I don't know, 20, 21 years old, fresh out of school. And I had food poisoning and I was having diarrhea in 1 hour about 16, 17 times, and along with nausea, vomiting. So it was very, very painful when I got to the hospital. So I was yelling and screaming. And then one word from my brother. So he came into the room, uh, and then he just told me one word: "Stop that." And then I looked at his eyes, and then that was it. Okay, nobody heard a peep from me again. Okay, so he reminded me that in our family we don't do that. Regardless of how much pain you have, you don't embarrass yourself, right? So that was the culture in my family. All right, so we have acute and chronic pain. There are standard definitions. We have characteristics for each one. Table 11.1 are the few. So acute pain is usually, okay, I'm saying usually short duration. However, long-term pain or chronic pain can have acute pain in between. How do I describe this? So acute pain, we know it's sharp. These are the characteristics. It's uh, sudden onset. Suddenly appears like tooth pain, for instance. That's acute. Um, it's predictable. So let's say when you eat something, oh, that's when my tooth pain um, starts, right? Or when you, let's say, have a bowel problem, and let's say you have a wound on your rectum, for instance, and every time you have a bowel movement, when the stool passes, that is really painful. It burns. Okay, so it's predictable, and they usually respond to pain medications. So these are some of the examples of acute pain. Chronic pain, which will now used to include cancer. Now they put cancer in a different category. Although cancer pain is chronic pain, um, they put it. The World Health Organization put cancer pain in a category all its own. But treatment-wise, it's really treated the same way as chronic pain. However, one thing to remember is chronic pain can have acute pain episodes. Does that make sense? Meaning, on top of the usual pain that they're experiencing, so let's say, look at the examples: migraine headaches. For those of you who have migraines, is the migraine pain always the same when it comes on? For those anyone here with migraines? Or let's say my low back pain, for instance. Okay, so I have a pinched nerve. I forgot which spinal nerve it is. So I have chronic low back pain, but then there are days wherein it hurts differently, meaning I have acute pain episodes on top of my usual low back pain, right? So there are good days, there are bad days, right? So those are chronic types of pain, like neuropathy, meaning these things never go away. They're always there, right? So you have, like I said, good days, bad days, but then you also have extra bad days. right? So you have exacerbations. That's what I mean by you can have acute pain episodes on on top of your chronic pain. So the period here, usually we say acute pain if it's less than 3 months or less than 6 months, and then chronic will be anything beyond that. The difference also lies on the pain description. So here you have descriptions here. Chronic pain will be more achy, dull, stabbing, burning, icy hot. So these are the pain descriptions for chronic pain, whereas for acute pain, it's more like um, uh, the descriptions are more because the pain is going acute. In the onset is acute, so they usually describe it as excruciating, for instance, um, sharp, for instance, versus dull. Um, and then we have, uh, we'll go to the pain categories next. So the breakthrough pain here, this is what I described as a pain on top of chronic pain, meaning in between your usual pain, you get these short pain episodes here, which is different from the usual pain that you are suffering from every single day. So the medications will also be different for breakthrough pain, meaning the usual medications we're using for your chronic pain will be ineffective for breakthrough pain. So you have to receive something other, I mean, something else for that breakthrough pain. So I mentioned cancer. Again, cancer pain is like chronic pain, but the WHO again put it separately. There has to be they put cancer in a different category, but technically it is cancer. So most pain we have, which are acute chronic pain, are usually nociceptive, meaning there is a physiologic um, cause, meaning there's noxious stimuli, there's injury to the either tissues or um, to the organ, for instance, or to the muscles. Okay, so that's nociceptive type of pain, meaning there is a cause for the pain because there is actual noxious stimuli or injury to the tissues. Neuropathic pain doesn't have it. Examples of neuropathic pain are, have you heard of phantom limb pain for those who've had amputations?
Yeah,
Yeah, and then the patient still reports, oh my, they don't have the right leg, that they complain, oh my right foot, my right leg hurts,
yeah.
right? So that pain is real though. We call that neuropathic type of pain. So phantom limb pain falls under neuropathic. Okay, so that's an example. Others are the pain felt by diabetics when they have neuropathy. Also, the same pain as in, ever seen patients with shingles? The
Yes.
yeah, so that pain is also neuropathic. Um, you can say that, oh, that sore, that those skin lesions formed by the shingles painful, but that's not really the pain that they're complaining about. The pain that they have from shingles is deeper. It's more neuropathic in nature. It's not really the same. That's why if you notice, if you have patients with shingles pain, they're given something else. They're not given opioids, right? They're given antidepressants and anti-seizure medications because it's a different type of pain. It's more nerve pain rather than nociceptive pain. Nociceptive pain, or I'd like to call this the physical pain, can be cutaneous, meaning superficial. It can also be deeper, which is now called somatic. So these are now pain you feel in your bones, joints, muscles, they're called somatic now. And anything again superficial is called cutaneous. And then pain from your organs, such as when you're having stomach cramps, for instance, from diarrhea, or from constipation, that's more visceral pain from your organs. Let you read the rest. So here's neuropathic pain. So again, this is a different type. There is no physiological evidence here, unlike nociceptive pain, wherein there is actual injury to the tissues. Neuropathic pain, you have no evidence of that. And the usual description are shooting, stinging, pins and needles, kind of like the pain you feel when your leg falls asleep, or your arm, for instance, falls asleep. So that type of pain. Okay, it's weird, weird sensations.
Professor, can this caused by low calcium too or no?
No, those are different. Those are technically not pain. Those tingling sensations are literally just that, just sensations, but they're not painful.
Okay.
Okay, so please read the rest of the explanation. All right, I won't read that for you. For the summary, for exam purposes, so you have a nice table here, 11.2. So this will differentiate nociceptive. We have three nociceptives. You have cutaneous, somatic, visceral. And then we have neuropathic, which is a category on its own. So the test questions will be on the description and examples. We'll get to the management later. I have no questions on processing pain medication. This is about referred pain, so we'll skip all that. We'll go straight to the interventions now, the drug therapy. So we'll skip all these. This one we already described earlier. So there are several factors affecting your pain. I described sociocultural. We have gender also. Who are gender-wise? Who do you think can tolerate pain better?
Women, they give birth.
Female.
The women. The women.
All right. So you want to start giving birth, Richard? I mean, Israel?
No way.
No, just once.
No way. I'll stick to the manly pain, like
All right.
lifting weights, whatever.
All right. Whatever you say, man. I remember in Florida when I was still working there, we had 4 brothers. So these 4 brothers have a history. Okay, so they visit the hospital, and we were there were 4 hospitals in the Tri-County area. 2 are public, and then 2 are private. So they've already shopped around. They visit one ER after another, complaining of pain, looking for pain medication. So this is what you can say, they are who we call drug seekers. But again, because of the definition of pain, we couldn't really refuse or not believe that they are in pain, right? Because of that. Now, doctors have found they've tried several ways, meaning to convince the patient that they have no, there's really no physiological cause, but that proved to be a waste of money and waste of time, because the patient, even though the doctor did CAT scans, MRIs, PET scans, they did all the tests to find out what's causing your abdominal pain, and they couldn't find any physiological cause. But again, the patient is consistent with their pain complaint. Okay, and they are four brothers, all on disability. They're in their At that time they were in their early 30s. Yeah, all four of them are on disability because of the pain um, that they are experiencing. Okay, so well, I don't want to say the name, but they're two of them already had restraining orders against well, the hospitals have restraining orders against them because at one time two of the brothers assaulted the physician because the physician refused to give more than a certain dose of the medication, so they assaulted the ER physician, so they went to jail for a few days for that. But now they have restraining orders, which cut down their options in the hospital um, choices. So they were down to two, but word gets around pretty fast. But doesn't mean they were denied care. Okay, so they were still denied. I mean, they were still provided care in the other hospitals. Um, no, because it was different now because there was assault involved now. Okay, so that was different, of course. So that was the only reason why they were banned from the ER in those two hospitals.
Hmm.
We'll discuss pain in adults shortly. We can skip this part here. All this is saying is they are a marginalized population, meaning older adults. Same thing also with cognitively impaired patients. Pretty much, uh, they they have um, they have disadvantages. Okay, because of their belief. Let's say most older people believe that pain is a natural part of aging. That when you grow old, it's just natural that yeah, there will be pain because I'm getting old. That's not really true. You can grow old pain free. Okay, so it's not really and they need to be educated that no, it's not here. See, read this part here. So some older patients um, are reluctant to report pain. If so, feeling as if pain is to be expected and normal, and then also out of fear that pain signals pathology. But exactly the reason why they should report it so that we can see, well, what's causing your pain, right? It's not natural. It's not natural that you grow old and then you're in pain. That's not really correct. It's not accurate. Let's go to the next page. Assessment tools. So we have our widely accepted fifth vital sign. So on top of your regular vital signs, you're supposed to ask them routinely if whether or not they have pain. Then we have our measuring scales. So we have pain assessment must be comprehensive. So regardless of if it's chest pain, somatic pain, neuropathic pain, any pain, if the patient says yes that they have pain during your routine assessment, you have to complete a comprehensive pain assessment. So we use the PQRST. Um, the intensity is only one aspect. So you don't just say, oh, how bad is the pain? You don't stop there. So you have to complete the what is the description? Where is it? What makes it worse? What makes it better? All right. So we have to let's start with the intensity first because it's mentioned here first. So we have for most adults and older children, we can use the numeric pain scale, right? So teenagers, for instance, can benefit from these. So 0 to 10, or you could also use the descriptive pain scale, which can be a hybrid between numeric and descriptive. So no pain, worst possible pain. So you can either use numbers or descriptions. Or here's another one, visual analog pain. I mean, visual analog scale. Then you're familiar with in peds. You have peds now, right? So the Wong-Baker Faces tool, please use the correct tool, all right? So you can't, it's not appropriate for you to use the Wong-Baker Faces on, say, a patient with dementia, all right? Although the categories and the criteria are similar, but that's not appropriate. You don't use the Wong-Baker Faces on a 68-year-old patient with dementia, all right? We use something else. So here is our,
Professor,
yes, ma'am, sir.
what would you use? The regular number scale for
For which
older
one?
patient with dementia?
No, we have something called PAIN-AD, PAIN, and then AD, PAIN.
Okay.
It's for, the criteria are really similar to um, FLAC. Have you seen FLAC in PEDS? FLACC. Um,
I don't
yeah,
recall.
like activity, crying, consolability. What was F? What is the F for facial expression? Flat. Yeah,
I
it's
don't.
similar to that. It's using behaviors also in
Okay.
patients with dementia and also patients who have cognitive impairment. Let's say, they have um, cerebral palsy, for instance, right? Or nonverbal patients with autism that are nonverbal. So you can use the similar, but it's usually a set of behaviors, um, although similar to FLAC, but it's slightly different. We made it more appropriate for an adult who has cognitive limitations.
Okay.
Okay, so
Thank you.
here's our comprehensive pain assessment. So OPQRST. There's also a different acronym under the cancer chapter, but this one would work. So we have onset, provocation, so what makes it worse, quality, how do you describe it as best you can, a region or radiation, if it radiates, and then severity, of course, this is the pain scale that we're using, and then the time and duration, how long does it, when does it come on, how long does it stay, and then we have aggravating, alleviating, and associated symptoms. Okay, so that's a comprehensive pain assessment. Then you do this for any pain. So even if the patient you have a cardiac patient having chest pain, you do the same pain assessment. A patient with arthritis, the same pain assessment. All right. So this thing here, pain, is again very complicated to assess and treat. This can be easily a source of conflict between caregivers and patients. All you need to do is just maintain a good communication, establish a therapeutic communication, a relationship with your patient. So it involves trust. Okay. So again, set realistic expectations with the patient. Once you identify the patient's pain, you did your OPQRST AAA, and then assess the intensity using the appropriate pain scale. Then you and the patient set goals, right? The goal has to be realistic. It can't be zero, unless, of course, acute pain is possible. It's possible to have zero, but for chronic pain, it's impossible. All right, so just maintain a relationship. So you have to spend time, not just a few seconds answering your patients. So you have to spend at least 1 to 3 minutes, for instance, just talking about it. So once you gain your patient's trust, then um, your shift will be better. Well, I'm sounding really um, selfish here, but um, yeah, I'm just being honest. I want a good shift, so I don't want this patient constantly on the call light for the next 12 hours, right? So that's why I establish a good working relationship for the shift. He's in pain. He's probably, or he or she's probably gonna be on the call light, so I need to talk to this patient, right? Set realistic expectations. um, Establish that no, these are the medications ordered for you. Okay, so you can only get these this frequently, and you need to tell me when when it's starting. So you spend time, not just telling the patient, oh, I'll give it to you when I can. Okay, it's really these poor communications that get the relationship off, off. There's not a good start if you start the shift like that. So you talk to your patient, especially those who are in pain, because those are again your frequent call bells. All right, and then again, a very potential source of conflict for that shift. So that 3 minutes you spend for that patient, talking with that patient, establishing the plan for the shift, will mean a lot throughout the shift. And please don't discount. Okay, we'll talk about other pain relief methods. Don't just depend on one set. Don't be a one-trick pony. All right, don't just depend on medication. Every time somebody has pain, you give pain medication. Okay, be creative. All right, we'll discuss the non-pharmacologic pain relief measures. Just give it a chance. Okay, you may have be skeptical about them. I mean, how does music and how does distraction work? Believe me, especially if you have no other medication to give, meaning it's not time yet, you will have to depend on those non-pharmacologic pain relief measures. So pain management has to be approached in a multifactorial, because pain is also not linear. Pain is also multifactorial, meaning there are different problems that result from pain, meaning you're not probably not going to be dealing with just the pain, but the effects of pain on the patient. So look at this, for instance. Will pain be your only problem? Will there be anxiety, insomnia, or delayed surgical recovery? So these are just some of the complications that or associated symptoms that come with pain. Of course, you're in pain, you can't sleep, you get cranky, you don't get enough rest, then your cortisol levels go high, and that means your immune system's hyperactive. You're in a severe inflammatory state, so your wounds, your disease condition will not heal properly. Okay, let's go now to all those are nursing diagnoses. So this is just telling you what are the possible problems resulting from pain. So you had pain, but look at the resulting problems. You can have respiratory problems, because when you're in pain, do you tend to take deep breaths or shallow breaths when you're having pain? Shallow, right? And then because you're in pain, your gait won't be steady, so you'll be at risk for falls. You're in pain, so you don't have appetite, so you don't really eat that much or have any appetite for the food. The pain medications usually involve opioids, plus with having pain, you don't really like to be mobile, so you tend to stay in bed, so that causes constipation and so on. Medications can damage kidneys or your liver, for instance. Right? So there's impaired activity intolerance, impaired physical mobility, fatigue, etc. So you're not just dealing with pain, so you're dealing with the results or consequences of having acute or chronic pain. So most of the behaviors you see in clinical when they're cranky, these are all manifestations of being powerless, for instance. Okay, the patient obviously has no control over their pain. And then when you're not in control, base it on your own lives. When you don't have any control over something, what do you guys tend to do? You act out, right? There are behaviors that resulting from being powerless over something. So let's start now with pharmacologic treatment options. So analgesics questions on the quiz and the exam will be related to side effects. So first of all, recognizing what are these drugs, how do they work, and what are their common side effects. So do that for non-opioids, opioids, and for adjuvant drugs. So let's start with non-opioids. So we have one category called analgesics. So this is where Tylenol and aspirin fall. Then we have Nsaids. Nsaids are anti-inflammatory drugs. This is how they work. They inhibit prostaglandin synthesis. So that will explain why prostaglandin is a vasodilator on top of being a neurotransmitter for pain. So when you inhibit prostaglandin, since it's a neurotransmitter for pain, therefore no neurotransmitter for pain, no pain sensation. However, prostaglandin is also a vasodilator. So no prostaglandin, you will have vasoconstriction. That's why it damages the tiny vessels in the nephrons of your kidney, leading to kidney damage. It also deprives blood flow to the goblet cells in your GI tract, which produce mucus in your GI tract. So therefore, you're prone to GI ulcers and GI bleeding. And then finally, because again, they're vasodilators, they will also cause damage to your heart, to the tiny capillaries in your heart. So those are the three problems with NSAIDs. Long-term NSAID use leads to heart disease, kidney disease, as well as GI ulcers and bleeding. And of course, you know, Tylenol causes liver damage, right? And then aspirin also contributes to bleeding because they inhibit platelet aggregation. So here are some examples of your NSAIDs. Ketorolac is the IV NSAID. So most other NSAIDs are PO. We have Ketorolac, which is IV. But one thing to note, they are all NSAIDs. Okay, so they have the same side effects. Non-opioids can also be combined now with opioids. So different very popular combinations are the following. We have Percocet, which is oxycodone and Tylenol, or with ibuprofen. Okay, so Combinox is ibuprofen and oxycodone. So we have different combinations here, which will give you two benefits. So you have the benefit of a non-opioid, which works a different way, and then you have an opioid working a totally different way. Here are some examples.
Professor?
Go ahead.
A quick question. NSAIDs, but in the IV form, would it give you less GI side effects?
Not really, no. Ketorolac, for instance, is very harmful to the kidneys, so that's why they should only be given for a specific number of days. You cannot be on Ketorolac for a long period. Usually, I think it's 3 days for Ketorolac. After that, it can be harmful to your kidneys. But regardless of the type and formulation or route of your NSAIDs, they have the same side effects. Here's an uncommon side effects or little known side effect of NSAIDs, thrombocytopenia. It's not very common, and in fact, we don't usually monitor platelet counts when the patient is on NSAIDs. So I mentioned earlier about cardiovascular um, risk when taking NSAIDs for a long time. Here is COX-2. COX-2 is compared with the other, I'm talking about Celebrex here. So this one will have less, what does it say here? So I mentioned about the GI tract, right? So this one will cause the ulcer and then eventually bleeding. But and I mentioned about the cardiovascular risk. There's something here about it. It has a lesser GI side effect. One of them says that. Please read it entirely. Okay, I can't find it right now, but there's an exception here. One of the NSAIDs do not have as bad a side effect than the others. I can't see it right now, but it was mentioned somewhere here. Please read this safety alert. It is something to do with the cardiovascular, although we already mentioned that. I already mentioned about kidney damage, also related to NSAIDs. All right, and for Tylenol, it's 3 grams per day. And here are your limits: 1,000 milligrams per dose or 3 grams per day. So we can have extra strength Tylenol, that's 500 milligrams, and then you can have two tablets of the 500 milligrams, so that's 1 gram. Here's another safety alert. Especially with combination, when you have Percocet, Vicodin, for instance, or Lortab, all these preparations are combinations containing Tylenol. So the patient may have Tylenol on top of Percocet, Lortab, or Vicodin. So make sure you're aware of how much Tylenol the patient has had, because again, they're in the drug. Like Percocet can have 500 milligrams of Tylenol left. So be careful when you're also giving Tylenol on top of Percocet. All right, steroids. This is now, steroids themselves are not for pain. They are beneficial though for those patients who have inflammatory type of pain. For instance, we have arthritis, for instance. Okay, so patients with arthritis are in chronic pain. So you give steroids that will decrease joint inflammation. So this can be given PO or by injections. So this is now known as one of the adjuvant drugs, meaning they technically are not pain medications by composition, meaning by the way they were made. They're not for pain, but they are called adjuvant drugs, meaning they help treat pain. We have anesthetics. So this one will be best example of closing the gate. Now you put lidocaine, so you block the transmission of pain, therefore no pain sensation. I have no question on interactions unless you want to study this, but again, I have no question on drug interactions. Okay, this is way too much. I'm not testing that. All right, MLA is a frequent local anesthetic we can use this for before you insert IV, for instance, or when before you insert a Foley catheter, if the patient, if you have a patient who has really, um, very such a baby about these procedures, you can use MLOC. So that stands for eutectic mixture of local anesthetics. It's usually lidocaine. It's an ointment, so give this 45, apply it 45 to 60 minutes before the procedure. Okay, so let's say you're before starting an IV, for instance, before inserting the needle, you apply it ahead because it needs to be absorbed in the skin first before it works. But honestly, I don't think that works. But psychologically, it helps, I put MLA there. It's an anesthetic. So psychologically, the patient has some reassurance. Oh, yeah, that's good. Some are more topicals, icy hot, Bengay. So they fall under topical, what's that called? Rubefacient. I don't know what that is. Okay, opioids now. So we did adjuvants, we did non-opioids, now opioids. We have, I'm not testing 11.6. I'll go to, where's that? Oh, right here. All right, so this paragraph here, you have your routine opioids. We have morphine, gold standard. It remains to be the best today. You need something stronger than morphine. We have hydromorphone. Same opioid family, but hydromorphone is about 5 times at least stronger than morphine. So you'll see the dosing is much lower compared to morphine. Roxanol is PO. So Roxanol will be best for chronic type of pain. Or you can have it in tablet because Roxanol is liquid. Then we have MS Contin. So this will be either 10 or 20 or 30 milligrams. That's tiny tablets, also for chronic pain. Hydromorphone is only for acute pain. Right, so here, oh, my mistake. It's 8 times stronger than morphine. When I said 5 times, I just quoted a previous employer. I worked for a pain management doctor. He had a pain clinic, and that's what he kept saying to the patients. He kept saying 5 times stronger than morphine. Okay, so that's how I quoted it. We have these also fall under adjuvants, so more adjuvant drugs. Again, techniclonidine is for blood pressure. And antidepressants, of course, are for depression, but they work for neuropathic types of pain. So we give antidepressants for those with fibromyalgia, with um, neuropathy, diabetic neuropathy, or shingles pain also are given antidepressants. Here's a safety alert regarding antidepressants. Please read them on your own. And that's it. No, GABAs. So you're familiar with gabapentin, right? The ones used for, it's an anti-seizure medication also, but used for peripheral neuropathy in diabetics. And here are your anti-seizure medications, also used for neuropathic pain. So they give them together with antidepressants, and they even work better. I'm not testing this dosing guidelines. We're not doctors. We're not doing the doses.
What about ion channel blockers, Professor?
I'm sorry.
Ion channel blockers.
Ion channel blockers. Those are anti-seizure medications.
Okay.
This ones, yeah, they're all anti-seizures. So you'll see them again later in module 10, I think.
So we're supposed to know that also?
Yeah, the anti-seizure medications.
Okay.
Again, I have no question on the dosing. We don't take care of the dosing. Methadone is more commonly used now to treat addiction. So they're not technically used for pain. They can be, but um, not popularly anymore. They're more used again to treat opioid addiction. Sounds um, ironic, right? You treat opioid addiction by giving opioids, but it works. I'm not testing the other routes here for pain medication because we do have, besides IV, we can give it intrathecal, meaning into the bone. Um, so I'm not testing those. Only POIV and transdermal. All right. So questions on the quiz will be scenarios, and you're expected to know these pain management guidelines and principles. Example is this one. So if you know the patient is going to be in pain, such as a post-op patient, so do you expect a patient who just had surgery to be in pain?
Yes.
Yeah, so do you wait for them to ask for pain medication?
No.
No.
So you offer it, okay? So let me emphasize. What does as needed mean? What does PRN mean?
When the
As
patient com-
I guess.
Go ahead, Sheila.
when the patient ask.
No, that's not what it means. Okay, let me clarify this right now. Don't wait for the patient to ask for it. That's not as need what PRN means. All right, so you don't wait. You offer it because you expect the patient to be in pain. So rather than wait, because look at this guideline here. So analgesics should be given at regular intervals rather than on demand, meaning you don't wait for the patient to, I mean, you don't keep quiet. Oh, the patient never asked for pain. I'm not going to offer it. I'm not going to ask. I'll wait for them to ask. Well, remember earlier, especially the elderly, are they open to asking for pain medications? No, right? They may have false beliefs about pain that, oh, I'm supposed to be in pain, right? So you offer the pain medication. You do not wait for the patient to ask for it. Is that clear?
Yeah.
Yep.
Professor, I have a question.
Yes. Uh-huh.
So what's the difference between PRN and standing order?
Oh, standing order, it's scheduled, meaning it's either twice a day, 3 times a day. As needed, you have a frequency also, every 4 hours, every 6 hours. So you have, as the need arises, because the PRN stands for pro renata. It's Latin for as the need arises, meaning if there's a need for it, then you give the drug. All right?
Okay.
All right. Equinogesia. This is significant when we're trying to discharge the patient. So, for example, the patient has been getting 10 milligrams of morphine. Let's look at there's a table here. Where's the table? Right here, 11.9. So let's say the patient was on 10 milligrams of morphine IV while they're in the hospital. When you discharge them, what should the doctor write on the prescription to give them the same pharmacologic effect? Or to be specific, same equinalgesic dose. So 10 milligrams IV of morphine is equivalent to 20 to 30 milligrams PO. Why is it higher? PO.
It takes longer to reach the peak.
Yeah.
Or to go for the liver.
It's like it has like a longer therapeutic effect, I guess.
First pass
Remember,
effect in the
okay,
liver.
very good. It's the first pass effect. Remember, the liver gets rid of half of it. So that's why the oral route must be higher, because remember the first pass effect you learned in pharmacology. All right. So anything you take by mouth, half of that will be eliminated, approximately half. So you want to get rid of the first pass effect, give everything, avoid the oral route. So you can either do sublingual. Sublingual is not oral. Sublingual is in the tongue. It's absorbed in the tongue. So we have on the skin, for instance. Okay, so only the oral route will have the first pass effect. So we only have, not all here, so we only have a few drugs that have a IV to PO equivalent, namely morphine, codeine, hydromorphone, and meperidine. So these are the only four that have a parenteral and PO equivalent. The others don't. Tylenol has an IV form. We call it Ofirmib, but it's not used for this type of pain. Ofirmib is only given for post-op patients, and not all are indicated for it. I'll explain it another day. So a problem with opioids is always three. So we have one, which is tolerance. We tend to ask for higher doses over time. Then we have dependence. Dependence is physical dependence, meaning when you stop the drug right away. That's why we talk about the Equinogesia, because we need to continue the opioid at home, because otherwise they will have withdrawal symptoms, because it's a natural reaction that the patient's body will have physical dependence. Dependence will start as early as a few days to up to a week. Okay, so even if you're only in the hospital for maybe 3 days, 4 days, or maybe 1 week, you will still have physical dependence. And it's important the patient realizes this, okay, because otherwise they will have withdrawal when they stop it right away. So that's because of physical dependence. And then addiction, of course, is now a more of a psychological problem, although it's a disease, but this occurs when the patient already starts taking the opioid for reasons other than pain. PCA, this is of course the using opioids, either PO or IV. Did you guys hear there's a PO PCA?
Yeah.
Yeah, but it's not very popular. I mean, it's a tablet, but there is a oral PCA. And then now we have non-pharmacologics. We have, I'll let you read these because these are positions not involving drugs. Okay, so these are using distraction, using music therapy, um, here positioning. We have heat and cold applications, range of motion, exercise, massage. Sounds good right about now. Are you open for business, Miss Decker?
No.
We have distractions, that includes music therapy, guided imagery, hypnosis, and prayer. Okay, so we have different options here. So when you're at a point wherein you have nothing to give the patient, meaning it's too soon for the next dose, please remember chapter, what is this, 10? It should be chapter
11.
what, 11?
That's
Yeah,
pain.
so remember, yeah, so remember this chapter. Okay, you do have other techniques here, so please give them a chance. I know you're skeptical about some of these, but I mean, if you have nothing else, what have you got to lose, right? Same thing for your patients. I mean, you talk to your patient. Right now, it's too soon for the next dose, so we may as well try these, right? Now, for older adults, again, these are marginalized populations. Just be careful with these, though, because remember, there are physiological changes in related to aging, meaning their kidneys. Consider their kidneys, for instance, because all drugs have to be eliminated by the kidneys, but because they have decreased glomerular filtration rate, so consider the dosing, okay, and the frequency of your um, medications, right? Because before you know it, the patient already has um, overdose. Okay, I'm just looking for the, it's not here. Okay. Right, let me go back to opioids because I think I skipped over the side effects. All right, here. I did skip it. Page 183. We have the side effects of opioids here. I mentioned tolerance. This is the definition of tolerance. Is characterized by the need for increasing doses of medication to get the same pain result. Meaning, today you may be happy with 2 milligrams of, let's say, Dilaudid, okay, and then tomorrow you found yourself, the patient is now um, pressing the button more frequently. Okay, that doesn't mean they're having addiction. That means they develop tolerance. Just like alcohol. Remember the first time you drank alcohol, you were buzzed with, I don't know, one shot. Now it's taking a whole bottle before you even start to get dizzy. So that's tolerance. Addiction, like I said, this is now a compulsive behavioral pattern. Again, the purpose of this is now psychic effects, meaning the patient doesn't have pain technically, but now is taking the opioids for the high, okay, the euphoria that it gives them. Side effects. So for opioid naive patients, meaning opioid naive, you're not used to taking it, you only take it sparingly, or maybe it's the first time you've taken it. Respiratory depression is your #1 problem because, of course, that will cause death. Other common side effects are nausea and vomiting. Another is constipation and pruritus, also urinary retention and pruritus. Urinary retention is the same mechanism as what's causing constipation, because remember, opioids are CNS depressants, so they slow down everything. So peristalsis slows down, bladder contractions also slow down. So these are the most common uh, side effects. Now you develop tolerance to these side effects, meaning over time, the more doses you receive of the opioids, the less you'll become the less chance you'll have of respiratory depression, the less chance you'll have nausea, vomiting, the less chance you'll have urinary retention, the less chance you'll have pruritus or itching. Constipation, though, will always remain. There is no tolerance. You do not develop tolerance to the constipation. It will always be there, meaning um, unlike respiratory depression wherein you've been on opioids for a week now, um, that's not likely to happen anymore. But constipation never goes away, so it has to be managed. And that's it. Any questions for the quiz next week?
Yeah, so what's exactly on the quiz?
Pain. Well, I'm going to send you the recording, so just follow what I said wouldn't be tested.
Okay,
All right.
Thank you.
thank you.
When are
Would
we
you
getting our
test
grades?
us on the conversion for the opioids?
What was that, Yan?
Would you test on us on the conversions for the opioids? The equal, whatever.
Yes.
Like